And now we will move on to the next part, which might be a little bit funny. It's a duel between the doctors, Sverre Eika, and Professor Emeritus, Helge Waal. So, I'd like to say a few words about the two of them. They have both been very important voices when it comes to treatment of especially people with opiate use problems. Helge Waal is a Professor Emeritus. I remember you said last time we were in such a debate that that's an abbreviation for old man?
Old and grumpy.
Old and grumpy man, okay. And I like those. With the Center for Addiction Research at the University of Oslo. He, as far as I know, started his career working as a young doctor at the very first Norwegian specialized treatment clinic for drug addiction, the State Clinic for Narkomania, in the 60s. He was also a supporter of the first community-based program, the Solja Collective, and one of the first promoters of methadone maintenance therapy in Norway. So, in many ways, Waal has been a radical and a first of many things, and an important professional when it comes to developing, evaluating, and defending the Norwegian program for opiate replacement therapy, also called as medically assisted treatment, with the abbreviation called LAR. And I think we can say that Dr. Sverre Eika is another rebel. He's challenging the rigidity of LAR. He has been called the drug addict's doctor in the media several times due to his way of treating some of the most badly affected population of people with addiction problems here in Oslo at the City Missions program called 24/7. He has a reputation among some segments of the field for being pragmatic when it comes to having a lower threshold when it comes to using opioids that are not traditionally used in the LAR program. He has said that when he was working with cancer patients, he was able to use the whole medical catalog to ease the pain for sick individuals. But when treating opiate-dependent people, doctors are constrained. And here lies, I think, some of the discussion that has been between the both of you. So I will start off with a couple of questions for Helge Waal. For many years, you have written official reports on substitution therapy in Norway, and can you tell us what substitution therapy is and how it is practiced in Norway? If you could also say something about how it has changed over the years and why.
Well, the Norwegian system is a national coverage system, which is built upon the cooperation between the municipalities, social authorities, and the medical doctors in the municipalities, and the health corporates or the hospitals. And all the hospitals are obliged to have a MNT, OMT program, and it's also defined in the patient's rights that a patient with opiate dependency has the right to treatment. There's not a question, he has a right. And there's also, all hospitals has to have commission to judge the indications for this treatment, which is solely dependent upon the diagnosis of opiate addiction or dependence. If that's the case, regardless of age, regardless of sex, regardless of other types of problems, he has a right to treatment. Then the question is how to do it. We also have a yearly report built upon each patient should be evaluated according to his progress and his situation. And this is the information for all individual patients is gathered in a report which is discussed twice a year at a meeting of the leaders of these opiate maintenance treatment centers.
Yeah. And what kind of medicines are being prescribed in this program?
In the program follows the regulations or the recommendations of the Health Directorate, which is that the patient should be treated either with buprenorphine medication or with methadone. The buprenorphine is regarded as to be the first choice because of less dangerous and perhaps also less problems with different types of rehabilitation on buprenorphine compared to methadone.
So the goal of the program is stabilization.
The goal has been developed now to be divided into rehabilitation on the one hand, which is ideally measured as to the optimal rehabilitation and drug-taking control for each patient, or stabilization. that stabilization is primarily a harm reduction aim, but each patient should sort of try to stabilize on that level of drug taking that he sort of insists on or likes or prefers.
Okay, interesting.
Which means that you can take drugs without ever being, when the OMT is not stopped, even if you are taking different types of drugs in addition.
Okay, and so Eika, you have worked with drug addicts for many years who have great difficulties with the treatment program in Norway, as far as I've understood. And if you could tell us something what you think are the main obstacles for these patients, and if you want to change LAR, what would you change?
Thank you for the invitation. That was a big question. I worked with drug patients for 10 years, and that is the most heavy users on the street in Oslo. And half of them, 50% is not from Oslo. So it's people from all over the country who ends up on the streets in Oslo. So we got a selective population of people who don't get LAR, who don't want LAR, who is in LAR but is on the street to buy the rest of the medication they need to function, because LAR is so strict. And it's really a desperate situation, because their day is filled with the need for money and buy the next dose of dope and benzo and amphetamines. So they are trapped in this bad vicious cycle, and they are really sicker and sicker. The average age is now 45 years. So they have had hepatitis C for 20 years, they have injected for 20, 30 years, so they start to develop kidney failure, cirrhosis, they got a lot of wounds and thrombosis problematics, they got loose iron, they got anemia, so it's a lot of physical problems. And it's really easier to help them when they got a lot of physical problems, because then I work together with doctors at the hospital, and use them as co-forskrivere, because I have developed methods through the jungle of laws to help these people without losing my right to prescribe medication. Because when you help these people in this way, you get reported to the fylkesmannen, because LAR has monopol, if that's an English word, to treat these people. So when you are on the streets, and 60% of a LAR patient buy things on the side, that tells a lot about people who got the wrong medication or too little, or the wrong medication and the wrong medication. And they got one foot in both camps. It's very hard to get rehabilitated when you are on LAR on one side and get the medication, and you still have to go on the streets and buy benzodiazepines or sell your methadone and buy heroin or something. So that's a very typical picture. So it's really a question of how to get medication for the patients, and how to get people to pay for it. And if he goes to the fastlege or his doctor, he's not allowed to prescribe anything. If he goes to a pain doctor, they don't do substitution therapy. And it happens that they help, but they will send them to LAR. At the hospital, you can get good substitution treatment when you lie there. It differs. It's often random. Often I explicitly say what they must have when I put them into the hospital. But when they are written out and they are not in LAR, nobody follows it up. And then you got LAR. And LAR is very different from different parts of Norway. So because we have worked with LAR from all parts of Norway. And it's a long way in. Some LARs you have to go to your doctor and the social services, and both of these applications have to go to LAR, and you have to go there. And it's you don't know the result. If you know that these people, they have tried Subutex, methadone, heroin, morphine, benzo, they've tried everything. They are 45, 50, 60 years old. They know what they must have to get on their feet. And they don't know what they will end up when you sit on LAR after 2, 3, 4 months fight. And it's a rigid, authoritarian system with urine samples. This differs, but it is. So many people just fall out of it because of the tone when you enter the building. And they got a very difficult relationship for benzodiazepines, because it's really two dependencies. It's opioid addiction, and it's also benzodiazepine addiction. Most of these people start chewing benzodiazepines before they started with heroin. And so the benzodiazepine must get status as maintenance treatment. And you can never trust LAR if you get some Sobril or oxazepam. It's a little dose, and suddenly a new doctor starts, and they want to get rid of it. So it's very unstable. And when you have been in treatment and when you come to LAR, very often you live in a ghetto, like in Oslo. It's a lot of drug addicts in the same building. The doors hang on the police has kicked doors in, and it's a lot of drug addicts, and it's very difficult to keep a straight line when that's the case. And maybe the worst thing is that LAR don't help with somatics. So it's a very artificial division between people that are so seriously sick that they go in dialysis. They got big medical protocols with a lot of different medication. And the doctors at the hospital have to phone LAR to ask about A and B drugs. It should be an all other model. So, and one more thing just about LAR. We people here who have been to LAR in 20 years, they still have to get their medication every day. So you sort of never, you can never be totally rehabilitated. When you function, you should get your medication every 3 months, as all Norwegian patients do. So that was about LAR.
So, you would comment on this, Helge?
Well, it was a lot of different statements which it's difficult to comment upon in a short reply. But let me shortly say this. Yes, we have problems. And of course, quite a lot of the problems for each patient is not alleviated as it should be. On the other hand, this depends upon the cooperation between different levels and the different specialities within the health and social system. As to the general situation of problematic life situation, that is and must be a responsibility of the social services in the different city parts. And they're doing quite a lot of work now, I think, giving individualized help and outreach help to many of those addicts with difficult situation. And the city council or the city parts arrange for housing first situations and also individual follow-up as good as they can. Of course, it's difficult. And I must also say that, you say that, and drug addicts are nice people. Well, some of them are not as nice. Most of them are nice. It's sort of, drug addicts are as different as other people are. And some of them are quite difficult to help. That's a question that we often say that they have to have a housing. And we give them a housing, they complain, or some complain that there are other addicts in the house. Well, it's quite difficult to arrange for life situations without problems, especially for problematic people. So some of these problems are difficult, and we have to sort of even try to improve all the time. And we also, therefore, we have the system is built upon so-called responsibility groups, which should ideally be a cooperation group for each patient, consisting of their social service contact, their general practitioner, and their specialist services. Now, this responsibility group is an instrument which quite often doesn't function very well, but is a system that tries to attain a cooperation built upon a treatment plan for each patient. That is at least the ideal goal. Now, this said, I must also say, I think perhaps that Eika sort of describes a reality that's not that black as he states it is. Built upon the national status system, there is about 10% of the addicts or the patients in LAR that has taken any opiates the last month. So 90% has not done so. About 30% has taken cannabis. which is sort of more or less accepted as a problem within the large system. You're not very much restrictions for that. 40% has taken benzodiazepines the last month, which is seen as more problematic, primarily because, as we know, the co-use of benzodiazepines and opiates decreases the motor and psychomotor control. And all the problems we have in accidents and so on is usually caused by a co-use of benzodiazepines and opiates, and alcohol. And secondly, also quite a lot of the overdoses is caused by this co-use of different substances. So it's not easy to say, just go on using. On the other hand, you're not kicked out of LAR because of this. We are trying to discuss and try to diminish the co-use of benzodiazepines. So, and also as to the somatic problematic, we have established a quite close cooperation with the Unit for Infectious Medicines in the hospitals, and also for the HIV treatment projects, so that each patient within LAR shall be evaluated. And there is also it's a sort of statement that all patients has the right to have been evaluated as to treatment for somatic diseases. It doesn't always function, but quite often doesn't function as it should be. And that is the program for LAR, is to improve the services for somatic diseases, also for psychiatric diseases, and also for the problems of loneliness and age. That's quite a lot. The average age for patients is now almost 50 years in LAR. This means that they have the problems of age. Well, I'm 77, so I'm not impressed by 50 years, but there are some differences as to this significance of this. At least this is also a developmental direction, is to improve the services as to life problems connected to late age and loneliness.
I have a question.
I'm sad too much.
Yeah, no. It's but you always do so. It's okay. I remember I was watching like a YouTube clip of you from 2012. I think it was a documentary called "The Years That Passes," Åra som går, and you were talking about the funding of the LAR system, and that first it worked quite well with a limited amount of patients. And then the patient population has grown till approximately 8,000, but the fundings of the municipal services has not followed, which led to like a poorer follow-up system than it was intended to be. Is that still correct? Short answer, of course.
It differs between different municipalities. Some municipalities are quite well equipped and do really excellent work. Others are very poor and have poor work.
Yeah, okay. So to the question of the benzodiazepines, because you feel that it should be part of the OST program, actually, and you disagree with that?
That's two different questions. One is, should there be a maintenance treatment for benzodiazepines? That is a research area where most follow-up studies sort of say this is difficult. It's questionable whether or not you do people a good service. The other, how should we treat people with benzodiazepine problems within LAR, which certainly can be improved. And we have quite obviously changed some of the policies from being very strict as to being presently we try more to find policy or a treatment plan for each patient would diminish the benzodiazepine problems as far as possible, without sort of making it a large hindrance. So as to the maintenance treatment, this is a constant evaluation. It's an international and national research area. Probably the group making the new regulations has done a review of all the projects. They found two systematic evaluations, two small studies, which was probably more positive than negative, but not very positive. Besides that, there is now very documented evidence of the usefulness. And my primary statement is that why should drug addicts or drug users be evaluated more poorly and have the poorer treatment than other people? And in general, you don't treat anxiety, sleep disturbances, depression, life problems with benzodiazepines in general because it's a poor treatment. So why should the addicts be treated poorly, more poorly than other patient groups?
You think they are treated more poorly?
The same argument can, of course, be used on opioids. That's supposed to be used in surgery, where you break things when you got cancer patients. So the easiest thing would be have patients without any addiction at all, because then everything would go smoothly. Of course, when you let in of our patients, 19 of 20 had just as serious benzodiazepine addiction as everything else. And no matter what you do, they would go on the street to buy if they don't get from the system. And the little study you referred to was the Israeli one. Oh, so they tried.
The London one.
No, London one. So that was a study with a methadone patient who had unsuccessfully tried to reduce benzodiazepine use. And they got the lowest dose of clonazepam, also Rivotril, and one group was reduced to 0 in 6 months. The other one was followed with maintenance for 1 year. And after 1 year, I think 80–90% of the maintenance group were outside use, and 10% or something of the other one. So they have started use from the streets again. So I would say the opposite. It's a lot of patients, you can't stabilize them without benzodiazepines.
But do you think that benzodiazepines should be like prescribed to all patients?
No, of course not.
Okay, so
no,
it's limited.
You don't make an opioid addiction as well. Of course, you don't you use that as well. We talk about people with established addiction who are on the street and the legs fall off. I mean, you see them, and they are dependent on both of them, and you have to use both of them. And the thing with the negative cognitive effect, that you sort of, it's a synergy effect with opioids and GHB and alcohol. That's the same with, it's a negative cognitive effect with methadone as well. I mean, and then many of these people are not going to the university. The point is to get them out of a life-threatening situation, to get them stabilized, to get them somatic well, and start to work with them socially and see, is it rehabilitation, potential for rehabilitation in this patient, or is it just, does he want to continue to live under a bridge, but still like So I want to rephrase it all. I want it, they must have a right to medication. So it's not up to psychiatrists at LAR to say yes or no, but that he got right to medication that suits him.
But since he said, is it like, you said 40% of the OST patients? I know. I have already been told there's 2 minutes left or something, so... yeah, well, we can, if you have a comment on...
One comment.
Yeah.
For a few years ago, it stood in the prison regulation that the food in the prison should be nutritious, but not too tasteful. And that's a little bit telling of the drug of LAR. It's supposed to be a little bit punished. We have to allow them to have medication that they like, and we have to have the opioid spectrum like Switzerland, and I want to treat the whole group as palliative care, and with the same give the responsibility to the primary doctors, where 40% are started up in primary doctors, and it's a cooperation between the hospitals and the primary doctors, and nobody loses their license in this loop. It's a crazy division that LAR is going to put on A and B, and the fastlege has nothing to say, and the hospital are confused. So the system functions extremely poorly for those desperate people that I work with.
Yep. Okay, comment from Helge, I would suppose.
Well, it is not illegal for any physician to prescribe benzodiazepines for people in LAR. It's not even prohibited to prescribe opiates to people without outside law. But you have to give a sort of statement, and you have to describe in medical journals why you do it. If you're stricken off, or if you give a warning, it's because you sort of treat in ways that is regarded as dangerous and unsecure, and are unwilling to sort of regulate it in that direction. So, yeah, I think I disagree with the description of the realities for most patients.
Okay, so we ended there. We have a disagreement of reality. So that's interesting. I'm sure that we will probably continue this discussion at some later point again. So thank you to the both of you.